welcome back. This is the fifth lecture of the perioperative pain management, and in this lecture, I will focus on building a multimodal analgesia. In the last four lectures, first we started to learn about mechanism of pain, how we assess pain, why it's important to treat pain. Then we learned about opioids, then we learned about non-opioid analgesics. In the fourth lecture, we learned about special population, and in this lecture, we'll learn about how we're going to put things together to build a multimodal analgesia. So let's get started. Consideration when formulating a plan for perioperative pain management. How much pain is associated with a surgical procedure and how long is it expected to last? Is the procedure amenable to the use of regional or local analgesic technique? Are there particular patient factors that affect the choice of analgesic options? Specific regional analgesic technique like neuroaxial analgesia are contraindicated in the setting of abnormal coagulation or platelet dysfunction. Involve the patient with the decision making and get the necessary information. Informed consent. Always have alternative plan. Approach for postoperative pain management, pain assessment. Make sure when you go and see the patient postoperatively with uncontrolled pain, make sure the patient doesn't have complications like intra-abdominal hemorrhage with severe pain or compartment syndrome or ischemia. Consider the pain severity, character of pain, somatic, visceral, neuropathic. All of this were covered in the first lecture. Consider when choosing pain medication modalities, patient comorbidities, concurrent medication, drug history, what medication the patient had already received, use a stepwise approach, what route of administration you're going to choose, what pain modalities can be used at this time, drug potency, patient preference, and use a multimodal analgesia. Always be conservative when dosing opioid and continuously give more if the patient needs. Always document what you gave and send out to the upcoming provider. Monitor for response and side effects. This is the step ladder. Always consider giving medication that cover or prevent hyperalgesia like pregabalin, lidocaine, and ketamine. Fundamental drugs that almost every patient should receive unless contraindicated, the acetaminophen and NSAIDs, then weak opioid or strong opioid based on the severity of pain. It's interesting if you watch the progress over the last few years or decade that the old way of thinking that everyone should get opioid, that's the base of the pyramid, and then you can give others like acetaminophen or ketamine, and then some patient will get regional, and some patient will get lidocaine, dexmedetomidine, ketamine, etc. Now, the new way of thinking is completely upside down what happened in the past. So everyone should get regional anesthesia, Tylenol, NSAIDs. If not contraindicated, then your next will be something like lidocaine, ketamine, and only once needed and as a last resort, you can give some opioid. Most of the postoperative pain is nociceptive in character, but there are a small percentage of patients who can experience neuropathic pain postoperatively. So you must be familiar with the neuropathic pain, how you diagnose it. And usually it results as an accidental nerve injury. Doesn't need to be cutting always. Sometimes traction, compression, entrapment. And these patients present with a burning, paroxysmal shooting, electrical pain. Allodynia is very characteristic, hyperalgesia, and dysphagia. Remember the first lecture. Surgical procedures that are a relatively high risk of neuropathic pain include limb amputation, breast surgery, gallbladder surgery mostly open, thoracic surgery mostly open, inguinal hernia mostly open. In general, neuropathic pain responds poorly to opioid. So the answer is not always giving more opioid, and may benefit from addition of non-opioid analgesics, such as those that cover the NMDA receptor, alpha-2 agonist, or the alpha-2 delta subunit calcium channel blocker, gabapentinoid. Nociceptive pain responds best to opioid, NSAIDs, and regional anesthesia. Perioperative pain management modalities. Think about modalities: enteral, parenteral, PCA, intrathecal, epidural, local, infiltration, regional analgesia, or all of the above. Also, when you consider the route of administration, you have to think about the desired peak effect and the duration. So when you give IV here in the green line, you will get a rapid peak, but that will also rapidly decrease. So if you think about this is the therapeutic range, and this is the toxic range, or where you get side effects like respiratory, depression, etc. So the duration the IV lasts as a therapeutic, it is shorter than the duration of the oral. Sorry, the oral is here. So it's shorter than the duration of oral, for example. So the oral will be here versus green. So green versus orange. So although the peak to reach, it's slower to reach a therapeutic level, but it lasts longer in the system. You get the point. Again, similar thing here on the left side. So you rapidly can reach the therapeutic concentration, but drop down faster in comparison to the oral route. Oral route should always be your first option whenever possible. Its main advantage: non-invasive, easy of use, and self-administered. In postoperative analgesia, its main drawback is that the patient must be able to swallow and absorb the medication. This can be a problem in certain postoperative conditions or their frequent complications such as nausea and vomiting. Another consideration is the slow onset of action and more difficult dose titration, which in practice may lead to underdosing rather than overdosing of analgesia. Rectal is another possibility, especially if you can use oral. So the advantage of absorption from rectal mucosa is largely bypassing the first bypass hepatic metabolism of the drug, and the disadvantages are similar to oral. Intramuscular is another option. However, this should be avoided on patients with coagulation problems and can be used in patients who cannot take orally. And it has some placebo effect. Obviously, the disadvantage is the discomfort. Intravenous has the advantage of fast onset of action, as we saw, efficacy at lower dose and easier dose titration. On the downside, venous access must be secured. A higher risk of wrong dose has been reported in literature, and there is a greater risk of side effect. Non-traditional routes of systemic administration include transmucosal, conjunctival, inhalational, and intranasal. Let's talk about drug potency. It's an important concept when you decide which medication you want to give. So the way we think about this is to look at the number needed to treat. It's a simple concept that can be used to compare potencies of different pain medication. So the number need to treat basically is the number of patients who must be treated to obtain greater than 50% relief of moderate to severe postoperative pain. The lower the number need to treat implies greater analgesic efficacy. Now, if you look at most of the NSAIDs, for example here, the diclofenac and ibuprofen, this is really a good number need to treat. Look at the Celebrex here. While if you look at the gabapentin, this is really a high number, and this may explain, if you remember in the third lecture when I covered all this medication, the low efficacy of gabapentin. Now look at oxycodone, right? It's very comparable to Celebrex, very comparable to ibuprofen 600 milligram. So keep that in mind when you decide to choose. So Tylenol, for example, is 3.8, right? This is another diagram here, similar concept. So if you look at medication with number need to treat between 2 and 3, you have, this is Tylenol 3, which is with the codeine, diclofenac, ibuprofen, naproxen. And look at the tramadol, for example. It's less potent, which is not surprising if you remember the opioid lecture. Now, another important route of pain management is PCA. PCA is a method which allows the patient to administer the opioid themselves, most commonly in the vein or sometimes epidural space. And basic parameter usually set up basic parameters in the PCA include bolus dose, lockout interval, and you can give baseline infusion or not. The patient should be given a loading dose of analgesics to effectively relieve pain before starting PCA. This is typically happen in PACU. PCA require patient cooperation, so it shouldn't be used in patients who cannot understand how to use it. Compared to other type of systemic opioid administration, the main advantage of PCA are greater patient satisfaction and better quality of analgesia. Side effects are identical to other route of administration. The most used drugs are morphine, hydromorphone, and fentanyl. Hydromorphone is recommended as an alternative in renal failure. However, fentanyl might be a better choice, and it has no active metabolite. Meperidine is not recommended for use in intravenous PCA secondary to accumulation of its potentially toxic metabolite normeperidine. Lower dose and closer monitoring include continuous pulse oximetry and end-tidal carbon dioxide are recommended during early postoperative period in older patients and in patients with elevated risk of respiratory depression, hypoxia, and or opioid accumulation, as we discussed also in the opioid lecture. This table summarize the different loading dose, demand dose, lockout interval, and maximum dose in 4 hours for the most commonly used medication here, which is morphine, hydromorphone, and fentanyl. Usually for morphine, the most common starting dose is 1 milligram. For hydromorphone is 0.2 milligram, and the lockout interval is 10 minutes without basal rate infusion. And you can adjust it in case by case. Let's talk briefly about epidural. There is a separate lecture that I cover epidural, so I encourage you to watch that lecture as well. But this is a brief overview of the epidural. So there is plenty of studies and plenty of meta-analysis shows the superior efficacy of epidural analgesia over systemic administration of opioid, including PCA, mostly in the first 3 postoperative days, like day 0, day 1, and day 2. Advantages of epidural: greater analgesia, so lower pain score with epidural compared to systemic opioid. Cardiovascular, reduced risk of myocardial infarction and dysrhythmia. GI, earlier return of bowel function compared to, again, systemic opioid. Pulmonary, reduced risk of postoperative pulmonary complication. However, the efficacy of epidural analgesia is determined by few factors. 1, catheter incision site congruency. 2, choice of analgesic drug and concentration of local anesthetic. 3, rate of infusion and the use of boluses. 4, duration of epidural analgesia. So, speaking of site of insertion, it is very important to think about the site of insertion that should cover the surgery. So high thoracic epidural analgesia would give a greater local anesthetic spread than caudal, while low thoracic epidural is mostly cranial. So if you put it thoracic, usually it go more caudal than upper thoracic, usually go more caudal than lower thoracic. This is mainly due to the caudal expansion of the epidural space. The site of introducing low thoracic epidural should correspond approximately to the innervation of the center of the surgical incision. With high thoracic epidural, it should correspond to the innervation of the upper pole of the incision. And this is a general guideline in this table. So for example, if you have a thoracic incision for lung reduction or mastectomy, your catheter insertion should be anywhere between T4 and T8. Upper abdominal surgery between T6 and T8. And this is important. So if you have a lumbar placed epidural, don't expect it to cover an upper abdominal incision. Mid-abdominal, T7 to T10, lower abdominal, T8 to T11, lower extremity can be lumbar. And then it's important to assess the functionality of the epidural every day. So first, you can test for sensory to determine the level and laterality, and that's usually done by eyes test. Motor test, we usually use PROMAGI score, which is a score from 0 to 3. 0 means non-motor block, and the patient usually will be able to do a full flexion of knees and feet. 1 is a partial motor block, where the patient will be able to just move the knees. 2, almost complete block, where the patient able to move only the feet. 3 will be complete motor block, when the patient unable to move feet or knees. And remember, usually motor block is 2 segments below the level of sensory blockade. Finally, autonomic nerve blockade mainly apply to sympathetic nerve blockade, which is responsible for several potential benefits: cardiovascular, respiratory, GI, and metabolic. Only the sacral portion of the parasympathetic fiber may be influenced as well. The combination of local anesthetic plus opioid is believed to have a synergistic effect. The optimal duration of epidural analgesia has not been determined, but recommendations are that the infusion be continued for at least 2 to 4 days. Epidurally administered opioids have the distinct advantage of producing analgesia without causing significant sympatholytic effect or motor blockade. Analgesia occurs by way of a spinal mechanism and through a supraspinal mechanism following systemic absorption. The spinal mechanism occurs following diffusion of the drug into the spinal fluid and is determined by meningeal permeability. In general, the epidural administration of hydrophilic opioid, like morphine and hydromorphone, tend to have a slow onset but longer duration, and a mechanism of action that's primarily spinal in nature. The epidural administration of lipophilic, like fentanyl and sulfentanyl, has a quick onset but shorter duration, and a mechanism of action that is primarily supraspinal, secondary to rapid systemic uptake. In the opioid-tolerant patient taking more than 250 milligrams per day of oral morphine, sulfentanyl may be the epidural opioid of choice because of its high intrinsic activity. The dose of epidural morphine is about 5 to 10 times the dose used for intrathecal administration. A dose of 2 to 3 milligrams of epidural morphine is commonly used for lumbar and low thoracic epidurals. However, for less painful surgery or high-risk patients, lower doses can provide adequate analgesia with fewer side effects. For example, epidural morphine 1.5 milligram was as effective as 3 milligram for post-C-section pain and was associated with a 60% reduction in pruritus. Adjuvant medication may enhance analgesia, including clonidine and ketamine. Clonidine 2 mic per ml can be combined with an opioid and a local anesthetic and is usually infused at a rate of 5 to 10 to 20 mic per hour. Side effects limit its clinical usefulness, including hypotension, bradycardia, and sedation. The safety of epidurally administered ketamine has not been determined, and routine use cannot be recommended at this time. A new approach is the extended release epidural morphine, Depodor. The system consists of a morphine encapsulated with a liposome delivery system, which provides controlled release of morphine for up to 48 hours. Depodor is approved only for lumbar epidural administration. Side effects and complications. Side effects include hypotension, inadequate or failed block, pruritus, nausea, urinary retention, vomiting, and respiratory depression. Let's talk briefly about intrathecal analgesia. Intrathecal opioid administration is a very useful and simple technique that's unfortunately not used that often. For major abdominal surgeries with extensive incision, epidural infusion might be the best option. However, with less extensive surgery like laparoscopic, intrathecal opioid alone can be used for postoperative analgesia. A single dose of intrathecal spinal opioid can provide a substantial pain relief up to 18 to 24 hours postoperatively. Intrathecal analgesia with a variety of drugs is widely accepted practice for the treatment of both acute and chronic pain. Opioid analgesics include morphine, hydromorphone, meperidine, methadone, fentanyl, sufentanil are the most administered drugs. Again, hydrophilic opioid penetrate the spinal cord and bind to specific pre- and postsynaptic receptor within the dorsal horn. They traverse the dura slowly, bind to epidural fat poorly, and slowly enter the plasma. They tend to have slow onset of action and longer duration and provide broader band of analgesia. However, delayed respiratory depression is more common with hydrophilic opioid secondary to rostral spread. On the other hand, lipophilic opioids tend to bind to nonspecific receptor in the white matter. They rapidly cross the dura and quickly sequestrate in the epidural fat and quickly enter the systemic circulation. Generally, lipophilic opioids tend to have a rapid onset of action and short duration, and a narrow band of analgesia. Delayed respiratory depression is less of a problem with lipophilic opioids. Morphine is highly ionized and hydrophilic and does not penetrate lipid-rich tissue, as well as fentanyl. Intrathecal morphine reach maximum effect in about 45 minutes and lasts 18 to 24 hours. However, the fentanyl, as you imagine, act faster and stay shorter. So this table compare lipophilic opioid to hydrophilic opioid in terms of onset of analgesia, duration, CSF spread, site of action, and side effect. It's important to check and make sure that you are giving a preservative-free intrathecally and in the epidural space. Read carefully on the ampules. Sometimes they look similar, so this is why pay close attention and make sure it's clearly written either PF or preservative-free. Other useful analgesic additions include the alpha-2 agonist, NSAIDs, NMDA receptor, and others. Alpha-2 agonists alter pain transmission by binding to pre- and postsynaptic receptor within the dorsal horn of the spinal cord. Evidence suggests that intrathecal clonidine is synergistic with spinal local anesthetic, prolonged sensory and motor blockade, and causes less urinary retention than intrathecal morphine. Intrathecal clonidine does not cause respiratory depression or pruritus. Intrathecal doses of 150 mic are reported to increase incidence of hypotension, bradycardia, and nausea. The incidence of respiratory depression from opioid is not significantly different among the various routes of administration. Appropriate monitoring of patients receiving opioid analgesic is essential to detect those with opioid-related side effects such as respiratory depression. Delayed respiratory depression due to rostral spread of opioid to the respiratory center in the medulla is possible with epidural or intrathecal administration of opioid. Respiratory depression may occur up to 18 hours after hydrophilic agent, such as morphine, and the incidence of delayed respiratory depression is approximately 1 in 1,000 at a dose of 0.2 morphine and occur predominantly in obese patients. So the bottom line, these patients need to be in continuous monitor up to 24 hours. These are considerations for use of neuroaxial opioid in low resource environment. So a physician anesthesiologist in low resource environment must evaluate the appropriateness of neuroaxial opioid use, and their setting include availability of medical provider who can evaluate underlying patient comorbidities and risk factors, may increase the likelihood of respiratory depression, system to ensure reliable and accurate administration of non-opioid multimodal medication, availability of postoperative nurses who can detect respiratory depression, emergency response team in the event of unexpected respiratory depression, which may result from undiagnosed comorbidities or drug error. Example of patient and postoperative risk factor for respiratory depression in the obstetric population, and you can extrapolate that to general population. So perioperative, general anesthesia, desaturation in PACU, co-administration of IV opioids, co-administration of sedative, co-administration of magnesium, patient with cardiovascular or neurological comorbidities, obese patient, patient with OSA, chronic patient with chronic opioid use, and patient with hypertension, all of which are risk factor for respiratory depression with intrathecal opioid. This is an algorithm from the same paper, and basically it helps you to determine what level of monitor you need to use, and subsequently the dose. So patient risk stratification. If the patient has a low risk and they are healthy, then simply if it depends mostly on the dose. So if you are giving intrathecal morphine of less than 0.05 milligram or epidural of less than 1 milligram, then you can use routine postoperative vital sign monitoring and no additional respiratory monitoring required. This is an ultra dose. However, if you use a low dose, which is intrathecal more than 0.05 and less than 0.15, or epidural between 1 and 3, then you need to have a Q2-hour clinical assessment of respiratory rate and sedation up to 12 hours. However, if you are giving a high dose intrathecal morphine of more than 0.15 or epidural more than 3, then you need an extra monitoring. And the same thing if your patient has a preoperative risk factors, the one we mentioned in the previous slide, then in that case, you need a respiratory rate and sedation assessment, Q1 hour for the first 12 hours, then Q2 hour for the second 12 hours. Consider additional monitoring modalities like continuous pulse ox and capnography for this population as well. And look for extra perioperative risk factor. For example, we mentioned that in the previous slide, the general anesthesia, concomitant sedation like benzo, and intravenous opioid. Let's completely shift gear and talk about infiltrative analgesia, another simple modality that can usually be done by the surgeon at the end of the surgery. It's important to make sure that you inject in the subcutaneous tissue, not in the fat. And this is a link for a video that show a nice technique for local anesthetic infiltration. Meta-analysis found significant decrease in analgesic consumption and increased time to first rescue analgesic request, but no difference in postoperative pain score in a patient who had pre-incisional local anesthetic wound infiltration. Some randomized trials have shown that local anesthetic injection around small incision site reduce postoperative somatic pain, but is inadequate for visceral pain, of course. This is a nice summary slide that summarizes to you certain pharmacokinetic of local anesthetic. So local anesthetic bind to voltage-gated sodium channel alpha subunit. It inhibits the sodium ion influx and therefore inhibit nerve conduction. So common questions: what will determine the potency of the local anesthetic? Well, it's lipophilicity. Increased lipophilicity will increase diffusion through the cell membrane, and that will increase the potency. What determines the speed of onset? It's the pKa. Decreased pKa, more molecules are uncharged at physiologic pH. That will increase diffusion through cell membrane, and that will increase the speed of onset. Notice if you add bicarb, that can increase the speed of onset by lowering the pKa. Now, what determines the duration of action is the protein binding. Increased protein binding will increase duration of action, as well as by lipophilicity of the local anesthetic and by adding vasoconstrictors as well. Now, this is a nice table summarize or the differences between amino esters and amino amide. So as you see, amino esters example will have one I. So procaine, chlorprocaine, cocaine, benzocaine, tetracaine. While amino amide has two I's: lidocaine, bupivacaine, ropivacaine, mepivacaine, etc. The duration of amino esters usually shorter because the pKa higher than physiologic pH. The higher concentration of chlorprocaine than lidocaine also contribute to its faster onset of action. while amino-amide has a longer duration because the pKa is close to the physiologic pH. Metabolism of amino ester, usually by plasma pseudocholinesterase, forms of para-aminobenzoic acid, PABA, and alike to cause systemic toxicity. While, on the other hand, the amino-amide usually metabolized by liver through dealkylation, the P450 system, and therefore systemic toxicity may happen. Allergic reaction to amino esters, usually secondary to PABA, and allergic reaction to amino-amide, usually very rare, and if it happens, usually secondary to the methyl paraben preservative. Allergic reaction to local anesthetic. True allergic reaction to local anesthetic is very rare. Many of the reported reactions have a different underlying pathophysiological mechanism, like vagal response or systemic toxicity. Allergic reactions are, for the most part, associated with amino esters, with PABA, due to their different structure. There is no allergic cross-reactivity between the two groups. The diagnosis is based on the presence of the following symptoms in order of severity: hypotension, shock, cardiac arrest, erythema, bronchospasm, angioedema, and other skin symptoms. Let's go over the most common local anesthetic very briefly here. So lidocaine is the most widely used short to intermediate acting local anesthetic of amino-amide group. Usually it's 0.5 to 1%, used as an infiltrative analgesia or perineural or epidural. Bupivacaine is long-acting local anesthetic of amide type and with a higher potency than lidocaine and more pronounced cardiotoxicity. And the onset of action is very slow compared to lidocaine, but the duration of action is longer for many hours. We'll see in the next slide. Levobupivacaine, it's similar, but with lower cardiotoxicity than bupivacaine. It's available in multiple concentration. The ropivacaine, chemically related to bupivacaine, but slightly lower anesthetic potency and lower cardiotoxicity. It is available as 0.2, 0.5, 0.75, and 1 because the motor blockade is less markedly than the bupivacaine, and it's more commonly used in regional analgesia and anesthesia, mainly analgesia. Sensitivity to local anesthetic depend on the type of nerve fiber. In general, thin fiber are more sensitive with the same diameter. A demyelinated axon will be blocked earlier than unmyelinated one. A myelinated is more earlier than unmyelinated. So the order of the blockade first will be small unmyelinated sympathetic fibers, followed by unmyelinated C fiber that carry pain, followed by myelinated fibers for proprioception, touch, and pressure, and finally large myelinated motor fibers. This is very important to keep in mind when you are assessing, for example, spinal anesthesia or epidural or regional. So a classic, you give the spinal local anesthetic. First, you will see the sympathetic block, then the pain will be covered, then the touch and pressure. So if the patient is still able to wiggle their toes, it still doesn't necessarily mean they don't have the C fiber blocked for the pain. Clinically, a complete interruption of conduction in a mixed nerve manifests as a lose of sensation of pain, followed by temperature touch, the loss of proprioception, then the last one will be the motor. Now, another important thing to consider, the local anesthetic absorption. So the absorption of local anesthetic depends on the vascularity of the site. So of course, the IV will be all absorbed, right? Then outside the IV, you have the tracheal with the highest absorption rate, and the lowest will be the subcutaneous. So in between, after tracheal, will be intercostal. Now, this is important, especially with the newer facial plane block. So, for example, you will see, and I'm covering that in my regional anesthesia lectures. So, serratus anterior plane block, you will notice that if you are giving a local anesthetic and if you are monitoring the lidocaine level, you will notice a higher level compared to quadratus lumborum block, for example. So after tracheal and intercostal will be caudal, then will be cervical, then epidural, then brachial plexus, then peripheral nerve, and finally subcutaneous tissue. So again, so peripheral nerve, for example, if you have an adductor canal block, your catheter versus serratus anterior catheter, you will notice that more systemic absorption with the serratus anterior versus the adductor canal block, and you have to be cognizant when you dose that, and most likely if you are using lidocaine, you need to monitor the level. Now, what about adding epinephrine to local anesthetic? The advantage is to determine intravascular injection, prolong the duration of local anesthetic, minimize systemic toxicity. The disadvantage, decrease local blood flow, may cause ischemia if injected site is poorly vascularized. Systemic absorption will cause hypertension and tachycardia. There is no evidence of negative influence of local anesthetic on wound healing or on the incidence of infection complication. Epinephrine should not be used in ring block or penile block because of the end vascularization, and there is a risk of local ischemia. Onset time, this is another important concept. So if you are using, interestingly, a pre-made local anesthetic with epinephrine, usually that's formulated at the lower pH to stabilize the epinephrine. So more local anesthetic is charged. That means decreased absorption into the tissue and slower time onset. However, if you make a fresh mixture immediately before injection, the local anesthetic will remain natural PK. They will keep their PK, so no changes in the onset of action. This is a table or a cheat sheet that help you to make the mixture of local anesthetic with epinephrine. So it's important to know the dose here. And this table is another important table which you can use as a cheat sheet, or you can save this. It will show you the onset of action, maximum dose, and duration of action. I want you to notice that if you go to the literature, there are a lot of variability on the doses. I did my best to choose what I think the best references. So things that you have really to memorize is the lidocaine. So Lidocaine maximum dose without epi will be 4.5 milligram per kilogram. If you add epi to it, it will be up to 7 milligram per kilogram. Now notice the difference in the duration of action. Another very commonly used will be the bupivacaine and the ropivacaine. So slightly different dosing with bupivacaine is 2.5 without epinephrine and 3 with epinephrine, and Ruby is 3 without epinephrine and 4 with epinephrine. With increased plasma level, neurotoxic symptoms are the first to appear, followed by cardiotoxicity, which may be life-threatening. Cardiac arrhythmias with cardiovascular collapse occur at a level approximately 3 times as high as those causing seizure. However, this ratio is different from different anesthetics, local anesthetics. Always remember that monitoring the neurological status of the patient receiving local anesthetic can often prevent an resuscitatable cardiac arrest. So speaking of local anesthetic systemic toxicity, or LAST, very important to know the symptoms and signs and be vigilant and act promptly on these patients. So cardiovascular signs, it can vary between hypertension, tachycardia, to arrhythmias, to malignant arrhythmias, to cardiac arrest. Other symptoms for the CNS will be excitatory mostly, so agitation, confusion, twitches, seizures, followed by depression that can be a coma. Early non-specific symptoms will be numbness around the mouth, metallic taste, ringing in the ears, tinnitus. So it's very important to monitor this patient after doing a nerve block and with continuous heart rate, blood pressure, and EKG. So let's say you have a LAST case, local anesthetic systemic toxicity. Few things to remember that's different than the regular ACLS resuscitation protocol, that you need to reduce your epinephrine boluses to less than 1 mic or 1 mic per kilogram. Avoid vasopressin, calcium channel blockers, beta blockers, or other local anesthetic. And of course, it's important to rapidly administer the lipid emulsion 20%, which must be available anywhere you are doing regional anesthesia and analgesia. So the starting dose or the bolus dose is 1.5 ml per kilogram over 2 to 3 minutes, followed by an infusion dose of 0.25 ml per kilogram per minute, ideal body weight. Now, if you don't remember that, just take a bag and finish it as soon as possible. So the bag usually is 100 ml, and if you have a 70 kilogram patient, you can finish that bag quickly while you remind yourself of the dose. Of course, you need to continue monitor these patients for a few hours after that and send them to the ICU. And you can use the AZRA checklist always to remind yourself, and it will be nice to print it out and put it in the regional anesthesia cart or on the area where you do the regional anesthesia. So speaking of regional anesthesia and analgesia, in general, it's provide the superior analgesia to systemic administration, The duration of action depends whether it's single or catheter. We will have a few lectures that cover regional anesthesia, so please make sure you watch them. Now, we finished talking about all the analgesics that we have. So now let's learn in the next few minutes how to build the multimodal analgesia. So it's important to go back to the first lecture and remember the 4 elements of the pain processing, starting by the transduction, transmission, modulation, and perception. When you are building a multimodal analgesia, it's very important to keep in mind to cover these 4 elements. So, for example, medication that cover transduction, NSAIDs, antihistamine, local anesthetic, opioid, modulation, NMDA receptor, spinal opioid, transmission, mainly here, peripheral nerve block, local anesthetic, and perception, you have the opioid, mostly alpha-2 agonist. So the optimal strategy for multimodal analgesia entails maximizing the use of non-opioid analgesic to reduce the patient exposure to opioid. Now, this is a summary infographic that I would recommend you keep. I like to call the multimodal analgesia the puzzle game. So now the pieces of the puzzle will be your neuroaxial analgesia, whether epidural or intrathecal morphine, regional analgesia, whether it's single shot or catheter. I added the local infiltration here, which is not necessarily a regional analgesia. And then your pharmacological therapy. So everything inside this box covered on the previous lectures, mainly lecture 2 and 3. So notice I bolded some of these medications, which is highly recommended based on the available evidence, and the size also correlates with the evidence that I found supportive for this medication. The one in red, these are medications that showed a potential to prevent chronic post-surgical pain. You may add to that the ketamine, however, still there is no much evidence to support, but it's potentially helpful. So think about the medication bolded, bigger size, red color that you want really to use in most of your patients. And then you have the non-pharmacological method, which is very important. Education, psychological support, acupuncture, as I mentioned, there is no much evidence there. The TENS unit, transcutaneous electrical stimulation, heat, cold or ice, abdominal binder, knee brace, and rehabilitation. So if you take all of these, and these are the pieces of the puzzle, so pick from them and put them together to build up your multimodal analgesia, keeping in mind that also you want to cover the transmission, transduction, modulation, and perception. So building on that concept, there has been multiple attempts to came up with protocol. It's nice to have protocols. So this paper, it was published in 2016, and it's some practice guideline from ASRA and ASA committees to build a guideline for different procedures. So, and again, you see the concept. So if you have a thoracotomy, these are the pharmacological, remember the previous slide, the puzzle game, regional neuroaxia. Now, notice the multimodal in all of this, which you think about it, it's about the same. Now, when it comes to regional, this is continuously evolving. So paravertebral block, nowadays we have the ESP. So I will cover that in the regional anesthesia, regional analgesia lecture. But you get the point. And this is continuously evolving, especially the regional analgesia. So pain control regimen should be tailored to the need of the individual patient, considering the patient age, medical and physical condition, level of fear and anxiety, personal preference, type of surgical procedure, and response. Neuroaxial and regional analgesia anesthesia seem to be the best preventive. Please don't forget the preventive analgesia. NSAIDs, acetaminophen, can be given orally before anesthesia. Notice I skipped that because it's plus minus. Following minimally invasive intra-abdominal or minimally invasive surgery in general is good. Now, for example, let's say we have a major open abdominal or thoracic surgery, then please consider neuroaxial analgesia. Use continuous epidural analgesia if possible, and if not, or you can use plus minus lidocaine or both of them, especially if you don't have epidural analgesia. For neuroaxial analgesia, morphine can be given via epidural or intrathecal, as we discussed in the previous slides. Don't forget the respiratory depression predictors and risk factors. And now, it's very important to have protocols. Therefore, as you probably most of you aware of the ERAS, which is stand for Enhanced Recovery After Surgery, which eventually has a society. They have a very nice website. And in their website, if you go to guidelines, there will be protocols for different type of surgeries. I highly recommend that you go there and you familiarize yourself with their protocols. Now, I will wrap up quickly with few slides about managing patient in resource-limited setting. This is very important for places that they don't have the advantage of all the modalities we have here in the US, and also for people who like to go in missions and treat people pain there. So this is, I really like this because it gives you an important concept, and actually it motivated me to start the whole education series. So the IASP conducted a survey in 2007 in resource-limited setting and find that 50% of respondents, and the question was, what are the barriers to good pain management? So 50% of the respondents had received education related to pain medication. Over 90% felt that it was insufficient. So education is very important. For this reason, the World Federation of Society of Anesthesiologists established the Safer Anesthesia from Education course. So there are multiple courses for pediatric obstetric anesthesia for pain management. I recommend you check and see the website. There are very nice interactive tutorials. Now, what's the problem with resource-limited setting? So you have limited access to medication and equipment, inability to provide safe postoperative monitoring, limited access to higher level of care, lack of critical care support, poor funding, poor infrastructure, lack of disposable facilities, limited education, limited research, and limited internet access. When considering pain management strategies for resource-limited setting, the following rule should be considered. Freely available or inexpensive drugs require minimal monitoring and workload impact, safe with minimal possible life-threatening side effects, and easily implementable by staff after minimal training. In 2017, the WHO listed essential medication that should be available and mostly available in resource-limited setting and encouraged to be used. Local anesthetic, acetaminophen or paracetamol, opioids, codeine, fentanyl, morphine, non-steroidal like ibuprofen, and ketamine. These are the core drugs that usually available and usually used. Now, this is a summary table that summarizes some recommendation for different medication and modalities used in a resource-limited setting. I will leave that for you, but remember, when it comes to morphine, I hope you still remember that from the previous slides. If you give 50 mic or lower intrathecally or 1 mic or lower epidurally, you can just go by routine postoperative monitoring. Well, I mentioned that, the ultra-low dosing. And finally, don't underestimate the importance of having a scheduled paracetamol, acetaminophen, and ibuprofen. This is very simple, mostly available. It can be used not only in resource-limited setting, but everywhere. Just keep in mind alternating the dose. So if you remember the duration of serum therapeutic level from the slide early on, so this will give you a serum therapeutic level across the 24-hour, either from ibuprofen or acetaminophen. These are extra references. Thank you for watching. Please don't forget to subscribe to be up to date with my other lectures.